our final lecturer of this day 2 of the 2022 international meeting. Dr. Mohammad Abualhaj graduated from the University of Jordan with a master's in fixed and removable prosthodontics. He was later president of the scientific committee in the Jordanian Dental Association and is now on the Jordanian Board of Prosthodontics. He was a part-time lecturer in Jordan University of Science and Technology and is currently a faculty member of dentistry of the Royal College of Surgeons in Dublin, Ireland. He practices advanced prostho and dental implantology in his clinic in Amman, Jordan. Dr. Abualhaj travels the world presenting lectures and workshops in cosmetic prostho and implant dentistry, and we're delighted to have him here with us tonight. Complications and indeed mistakes are an expected element in everybody's work, yet rarely do we have the opportunity to share in our mistakes. Dr. Abualhaj will show those common mistakes and how we can manage them in our day-to-day practice. Ladies and gentlemen, please let me present our final lecturer of the 2022 BN International meeting, Dr. Mohammad Abualhaj.
How are you? Hello. Good morning, good evening, good afternoon. I don't know why they gave me the last lecture. Maybe because the last thing that we want to see in our clinic is complications. So, can you all stand up, all of you? Stand up, yes, stand up. Stand up. Yes, I see you in the corner. Stand up. Take a deep breath, okay? Give me your attention for the coming 30 minutes. Thank you. Okay. Complications. Sit down, it's okay, sit down. Complications. We know that all of us has complications in his practice. One day, my mentor told me the following. To be a good dentist, you need 2 things, experience and knowledge. And both of them needs time. If you want to cut this time and make it short, you should take the experience from other dentists. The best experience comes from complications. We learn a lot from one complications, a lot of success, right? You know why? Because we hate complications. Do you remember the first failure you have in your clinic? Yes? For me, it was the 3rd implant. At that time, I hate implant dentistry. Why not to do crowns and the bridges? Why the hell to go for implants? This is life. In the coming slides, I will post my complications. 80% of the complications in this lecture is mine, okay? I'm not, it's okay, because all of us have complications. Any one of you don't have complication? You? All of us, okay. If we go to the literature, thank you, Dr. Baldin, he gave a good introduction for my lecture and make me change a lot of my presentation. If we go to the literature and look for complications, we have many classifications, some early complication, delayed complication, other complications, for example, surgical, prosthetic, a lot of complications, but at the end, it's still what? Complication. And we want to try to solve such complication. These are the steps for any dental treatment, from planning till follow-up. And in every step, we may have complication. To start, in this presentation, I will use complication, mistake, cause, problem in interchangeable way, just so you don't confuse. The first case, look at this case. Okay, look at this case. This patient came to my clinic before 1 month, and he asked me to do implant for the missing upper 6. And he told me the following. I went to Dr. X and Dr. Y. Both of them are unable to treat me. And some of my friends refers me to you. These words touch my ego, right? We are proud when the patient told you that I go to you because you are a good dentist, right? But the problem that Dr. X, he's my mentor in the postgrad. Dr. Y, my colleague, and he's a good dentist. The question is, doctor, did you do implant for this case? I put you the width and length. Yes, who can answer? Who did implant for this case? Raise your hand. Great. I can do it for him. When your patient told you that some dentist refused the treatment, ask yourself something. There's something behind the lines. What we should to do is to follow the basics. The first thing I have to ask, what is it? The first thing we should ask any patient. What? No. Yes, medical history. This patient did open heart surgery before 4 months and already take anticoagulant. So don't do periodontic work. Follow the basics. Most of our mistakes we don't follow the basics. We like to see blood. We like to see a lot of bone graft, soft tissue graft. But 80% of our cases are solved just by following basics. Okay? Look at this case. This case was done in 2011 by a good surgeon in Jordan. He can do the orthodontic surgery the same as you can do simply class 1. But what he missed in this case, he missed the teamwork. Why? Look at this case. Look, how many implants are unrestored, malaligned, long cantilever, every complication you may see. Why? Because he missed the concept of a prosthetic-driven implant treatment. A prosto, implant dentistry, there's a connection between specialty. It's a teamwork, but always the captain is prosto. But in this conference, just 2 lectures about prosto and the other about surgery. Maybe in the coming conference, you may change it, Dr. Claudia. Okay? Planning in everything and affect everything. One of the points we should think about, don't try this, because I'm told, but you are not. Okay, is the interarch space. Look at this case, my friend. If you have this case in your clinic, what do you have? Do you want to do? Who can answer? I will not go again underneath. Okay, who will answer this case? What? Raise the bite. Okay, another answer. What we have is a localized relapse in the bite. The best treatment is to do what? Orthodontic intrusion. So I can open, Dr. Murad, he's the orthodontist. He was my student and he's my colleague now. We open the space for my coming restoration, then I do my implant. And this is the final prosthesis, upper and lower, okay? Why I post this case? Look at this video. One of my colleagues, she sent me this video and she asked for help. Look at this video. Look carefully. Did you see the interarch space? There's no interarch space. And she asked me to treat this case without telling the patient that there's a mistake. The first thing, you should accept that you did mistake. We are human. By nature, we do mistakes. Okay? No one is perfect. We have another approach in treat interarch space defect. Look at this case. If this case is yours, and the patient came to restore the missing posterior area, for example, the missing teeth, what should you do? Who can tell me? Discussion. Yes, doctor. Osteotomy, another option. Dr. Baldini, no treatment. Okay, Dr. Claudi, refer the patient. Okay. Increase the vertical dimension, maybe. In this case, what I did, simply, this is the CBCT for the patient. I open the flap. I do with a bezo osteotomy. Create space. It's one option, or one of the valid option to create space when I have limited arch space. And this is fine. I need, I think, releasing incision, another stitch. These are the strategies I may use when I have not enough interosseous space. I can do orthodontic intrusion, bone recontouring, countersink of the implant, make the implant under the bone 2 millimeters, but don't forget to do flaring. Why? Because of the emergence profile in the future. You can use screw retained restoration. Why? Screw retained restoration needs just 4 millimeters, the least amount. But for cemented, you need 6 millimeters. You can go for full contour zirconia, but full contour zirconia, we can reach up to 0.5 in some material. But for ceramic metal, you need space for the ceramic and space for the metal. You can also go for bite raising, but if you are not familiar with bite raising, don't go for such treatment. You should be well qualified and know what's the occlusion and where we go. Don't just bite raising. No, it's not a magic. Some clinicians go to cut from the opposing. Take care, my friend. If you are the patient, if you accept cutting, cut for the patient. Take care. It's not ethical. Another complication. What do you think the most common complication for dental before osseointegration? Who can answer me? Before osseointegration. Yes, thank you very much, doctor. Infection. Infection can be the source of infection coming from instruments. Look at this. By the way, this patient is my friend. When you treat your patient, if the patient is your friend, always you have the complications. Always. Yes. You can see the infection from instrument, oral cavity, socket, adjacent teeth. I will just post one case. Look at this case. This case referred to me in 2011. If you look carefully there, upside here, yes, yes. What you see here? Fistula, yes. There's an implant at this area, already bought by another dentist. And they refer the case for me to do the final treatment. Look, who can tell me the scenario for this case? Yes, this absectomy, what happened? I think the light, because I'm tall, in front of my eye. I don't see anyone. Okay. What do you think the presentation?
I don't know, I send you.
I send you? No. Okay. Because the implant is not BMB, okay. This patient, when the dentist puts the implant in the central area, there is infection in the lateral area. So always check the adjacent. Why? It's basic. Until now, it's just basic. Just follow the basics. Check the adjacent. What's the most common prosthetic complication? Dr. Baldini. Dr. Baldini make me change everything in my lecture. He posted his slides and I change everything. Okay, screw loosening. It's common, but not in BMB. If you have a lucky enough, you can go through the ceramic metal and reach the screw and do it and rescrew it. But if you are dealing with the anterior area, you need another crown. But sometimes you may go for another crown even in the posterior. I advise you to go for screw retained. Don't deal with cement retained. You know, I will tell you why now. What can I do to avoid or minimize screw loosening or screw fracture? What can I do? This I told you, okay. Look at this slide. We should take care of occlusion. We should take care of the correct position of the crown. I will talk about the passive fit, especially in the full arch. Because most of the mechanical problem happened in the full arch, right? If you want to do full arch screw retained. Look at this case. What we need is to have fully seated passive fit. How can I get passive fit? Who can tell me? What? You ask about ligation between the post? Ligation or by...
No, if you have a multi-unit bridge, yeah?
Yes. How did you take the impression? Which technique? Open tray? Just open tray? Which material you will use? I will tell you a very good trick. Give me your attention. Look at this case. This case, upper and lower. And I want what? Passive fit. The best material to do impression for full arch as open tray is plaster. A plaster of Paris. Why? The most rigid material. A plaster, zero tolerance. Try it and pray for me, okay? This is the impression. After the impression, I will do the verification jig also with the plaster. If there's any misfitting in any thread, the plaster will break. This is the patient mouth. If I took an impression with a plaster of Paris, I never redo it. From 2013 till now, I don't use wires or floss or Dura-Line. Waste of time. Take either plaster of Paris or Imbrigam material polyether. Can I do it as digital? And this is the Imbrigam. Can I do it as digital? Can I do full arch as digital? Yes, you can do, but you should just follow one approach in your scanning. Occlusal with a little bit of buccal, then go buccal, then go lingual. If you go occlusal, buccal, lingual, occlusal, buccal, lingual, this will affect the algorithm of building the images, and you will end with misfitting frame. Okay? Another complication. What's the most common biological complication? Around 51% of our patients suffer from peri-implant disease, yes. How can I avoid them? Sometimes we can't avoid everything. But there's some techniques, it can help me. The most common reason is the retained cement. Okay. So I see the time, okay? Yes, retained cement. These are some techniques to overcome peri-implantitis. One of them, take your time in tissue conditioning, either by the provisional or by soft tissue graft to have enough keratinized tissue. Second thing, try to do a screw-retained restoration, because cement is the enemy of the gingiva. Third point, avoid abutment with deep margins like this, or deep implant. If you have deep implant, what should you do? For me, I will go for multi-unit. So I will change the level of the implant from under the bone, make it superficial as much as I can, okay? And I will take the impression using what? Open tray. Don't do a closed tray, because you will not have enough impression post in the material. Also, I will go for customized abutment. Customized abutment will change the point, make it away from the implant abutment connection, okay? Another complication. Look at this patient. This patient is my cousin. He came to my clinic 2015. I did 2 implants for him, 6, 5, and 4 as cantilever. Can we do cantilever for implant? Yes. Mesial or distal, we can do it. Okay. I do. Then, this is the final. I do staining in my clinic. This is the final. Okay. Go to home. After 8 months, he came to my clinic with this situation, because he's my relative. There's some, okay. Look, there's 3-in-1 complication. A fracture in the screw, a fracture in the tie base, debonding the tie base. Everything you want about biomechanical complication, you see in this case. What I do, I take another impression, I read the case. What I learn from this case? The first thing, never underestimate occlusal forces. The second thing, take care when you treat your relatives. The third point, which is the most important, never do the same thing twice and expect different results. Because I see my relative after 6 months. This patient, I bought another implant because if there's mechanical problems, maybe the patient is bruxism, and he's a bruxism. So I bought an implant in place of the 4. I do 3 implants, not 2 implants. Even in your life, don't do the same thing twice and expect different results. Occlusal forces can break an implant. This patient is mine. This patient was referred to my clinic with mobile crown. I remove the crown, the implant is fractured. We remove the fracture piece of the implant by using surgery, atraumatic, and will save much bone. Next complication. Look at this patient. This patient is my student. She is now practicing in Germany. She came to my clinic after consulting the endodontist, and the plan was to put an implant in the 6th area, first molar area. I do the sectioning, and this is the panorama. Do the sectioning, put my implant, and this is the panorama. I'm away from the nerve 2 millimeters, according to, okay. Then I try to conditioning the tissues, because if you want to condition the gingiva, start from day number 0, at the same time of implant placement. That is the final. It's okay. Then the patient called me next day at 6 a.m. Why? Who can tell me? What? مش سامعك. Yes. No, that was at 45. Not 1 day, maybe after 1 week, but just 1 day, not too much. This patient called me, doctor, I feel paresthesia in my lip. She feels paresthesia. Yes, why? Yes, I'm away 2 millimeters. Why she feels paresthesia? There's many. No, she didn't eat something. The implant I use at that time has large thread. When I do my implant placement, it's they cause compression on the bone. This compression in the bone go to the canal and compress the implant, the nerve. When she came to my clinic to unscrew the implant, I want to give her anesthesia. She told me, don't give me anesthesia, doctor, please. Okay. Remove just customized gingival former, unscrewing. Just when I screw a little bit, doctor, yes, anesthesia gone away. This happened to my clinic. Then, and this is what we call recommendoma or recommenditis. When you do something good for you, try to help your patient because you know him, but the result you see. Don't do recommendation. If you deal in the lower area and you adjacent to the nerve, ask your patient to call you once the anesthesia gone away, okay? This is the final, and I take the impression, customized impression, and this is the final crown for her. Good image profile. When you playing the lower posterior area, do infiltration, avoid the block, because when you do infiltration and you are drilling adjacent to the nerve, the patient will feel pain. So try to go infiltration, patient follow up. But do you think is that enough? No. Look at this case. Sometimes luck is much more than experience. This patient came to my clinic just to restore the implant. If you look carefully, the implant over the nerve, but the patient feel everything. Nothing happened to him. So luck is much important, but we don't know how to get luck. You know, Dr. Claudio? Okay. Coming complication. Look at what's this? What's this? Sinus, yes. Sometimes we are lucky to see this picture and we do sinus lifting and everything is fine. But sometimes my implant will go inside. This is my case. Who has his implant slipped into the sinus in this room? Oh, not Dr. Claudio. Just me do complication, right? I'm no. No complication, yes. In this case, I remove the implant through crystal approach with my suction, 2 minutes. And this is the implant. In 2019, I was in Dubai. I gave lectures about complications, about how to remove the implant from the sinus. It was Saturday. My flight to Jordan was Sunday morning. I arrived in Jordan by 8 a.m. Go to home, breakfast, shower, then go to my clinic to do implant dentistry, treat my patients. At 5 p.m., I have a case. And this is the case. I have an implant in the sinus. What should I do? I'm the one who teach others how to remove it. I try to remove it. 5 minutes, 10 minutes, 15 minutes, 20 minutes. I cannot remove it. I reach a point I cannot touch it. I take another CBCT. Now the implant under the eye. What can I do at this point? Yes? Yes? Simply, what matters is the patient, not our ego. I called one of my colleagues, please help me in this. He thinks I'm joking with him. Oh, no, I swear, please come to my clinic and help me. He took 5 minutes and remove it. Sometimes you can do the things, sometimes you are not. We are teamwork. What matters is the patient, not our ego. And we bought another 2 implants and everything is fine. Another complication. Look at this case. It's not complication, but look at this case. What do you think about this marriage profile? Is it good? Is it good, my friend? No, it's not good. Why? This is second premolar, and this is first molar. In reality, in natural teeth, the first molar is the same as second premolar? No. What we should have is the following. We should condition our immersive profile. And yesterday, Dr. Ahmed talked a lot about this point. The same for this point, the same another case, this case, this case. Why? Why we condition our tissues? Why? I know, for aesthetic. One reason. The most important reason because of food impaction and peri-implantitis. Look at this case. This patient came to my clinic 2016, I think. He suffered from three things. The first thing is food impaction, halitosis, and non-retentive crown. What should I do for him? The first thing is remove the crown. This is the panorama. I remove the crown. What I see is a lot of food impaction. So this is the reason behind halitosis. If you look at this fitting surface, uncleanable fitting surface, poor emergency profile, incorrect position, short abutment. The first thing to do, remove the abutment, put a gingival former. The patient, the body will heal itself. I put a gingival former. The question is, who can guess the scenario when the previous dentist bought this implant? Who can tell me? Yes, immediate placement. And he put the implant where? In the palatal root. Please, my friend, if you want to do immediate placement, put your implant in the right prosthetic position, not following the bone, follow the prosto, a crown down concept. In this scenario, he put his implant in the palatal root. So the end is like this. What I do is condition the tissues, again, redo the crown, but this is not ideal treatment because the problem is the position. As a prosto, we are not magician. We try to help patients. We try to help other dentists. But if there's something wrong at the planning, it will affect our treatment later on. The same case, another complication. This is my patient, 2012. In 2018, he came to my clinic with this scenario. I look carefully, a fracture screw in the implant, At that time, I put my implant on the distal root, the same problem. We put our implant in the right prosthetic position. How can I do it? I move the implant. Look at this case, also fraction in the Hicks. Drill through the root is a valid technique, so you can put your implant in the right prosthetic position. Then you can put a bone, you don't want to put one, it's up to you. But put in the right prosthetic position. This is what's important for this slide. Look, the last case. This patient, 16 years old patient, came to my clinic to restore hair missing lateral incisor. What's your option? Treatment option? Yes, tell me. Yes, Maryland. Yes, Maryland. I did the Maryland for her, and this is the Maryland. I like shade matching. I do it in my clinic. She likes the final result. Now, after 4 years, this is the final. After 4 years, she came to my clinic to do the implants. I put 2 implants for the laterals. This is a CT scan. Everything is fine. After 3 months, she came to my clinic with her father. I open a flap. One of the implant is failed, the other is successful. Same patient, same dentist, same implant system, same everything. One successful, one failed. Why? What? Unknown cause. I don't, why the cause? The same technique, everything was the same technique. Now, her father asked me, what's up, doctor? Anything wrong? What I told her father, I have 3 news for you. 2 good news and 1 bad news. What do you want to start with? He said, anyone, doctor, just tell me. The first good news, there's 1 success implant. The second, the bad news, there's a failed implant, but the good news that we can fix the failed implant. I redid the implant with bone graft, and this is the final. The final result after 4 months, I had bone graft, membrane, etc. Not sometimes, we did mistakes every time, but we should accept that we did a complication. We should do our best to solve the problem. Work hard, dream big, and never give up. We all do mistakes. No one is perfect. But what makes the difference is how you deal with complications. Thank you all for your coming on time. Actually, the presentation was not like this, but we changed it after the last 10 minutes. Faik, take a photo.
Finish?
Yes, finish.
Mohammad,
Yes.
thank you for...
Thank you, doctor.
my clinic, no complication.
No complication, just me do complications. Thank you.